hit the button.
Got it.
Good evening, everyone, and welcome to the July meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller, co-leader of the chapter, along with Dr. Amy Sapola, who is here as well. Well, as co-leader, Dr. Sapola is normally here, but I was especially sure she's going to be here tonight because she happens to be one of the panelists. So she's definitely here now. And Dr. Jacob Wolf is our chapter's outreach chair, and I don't know if he's going to be here tonight, but anyway, that's us as the leaders of the chapter. So tonight we are excited to be hosting our expert panel discussion on strategies for promoting women's health and fertility in the practice of integrative gynecology, moderated by Christine Kaiser, who's a licensed acupuncturist with a doctorate in acupuncture and Chinese medicine, and is a fellow of the Acupuncture and TCM Board of Reproductive Medicine. And in keeping with our efforts to alternate individual talks with panel discussions on the same or a related topic, this evening's panel follows Christine's excellent presentation last month on integrative approaches to the treatment of infertility. And usually, but not always, our individual webinars have taken a treatment-oriented tack, and some of our panel discussions have been focused on considerations of integrative practice. And that is going to be the case tonight as well. So the presenters on our diverse panel of integrative women's health specialists will be emphasizing the practitioner's perspective as they discuss some of their preferred clinical tools and approaches, their practice experiences and insights, challenges they've encountered, and so on, that kind of stuff, rather than analyzing the merits of the treatments themselves tonight. So Christine, who serves as the Connor Endowed Director of Reproductive Wellbeing and the Clinical Manager of Acupuncture at University Hospitals Whole Health here in Cleveland, will start off by describing the new 8-week lifestyle medicine fertility program that she was instrumental in developing at Connor, and how it makes integrated fertility treatments and education accessible to a broader patient base than would otherwise be possible. Dr. Amy, now also of Connor, is Doctor of Pharmacy, Fellow of the Academy of Integrative Health and Medicine, and an Institute for Functional Medicine certified practitioner. And she will talk to us about how she uses fertility yoga and food as medicine, both as tools and motivation for enhancing fertility and women's health generally. And Dr. Lee Hullender Rubin is a doctor of acupuncture and oriental medicine, licensed acupuncturist, and also a fellow of the Acupuncture and TCM Board of Reproductive Medicine, is the founder of Rose Finch Health in Portland, Oregon, and she's an internationally recognized practitioner and researcher in the field. And Dr. Rubin will speak about how she uses research findings to inform her practice and translate their conclusions into specific clinical measures. And she will illustrate this process through a case presentation on diminished ovarian reserve. And then finally, we have last but not least, Dr. Tara Scott, MD. She's the medical director of FABORM Health Akron. She has board certifications in OBGYN, integrative medicine, and functional medicine, as well as many other advanced credentials and board certifications. And she has come to be known popularly as the hormone guru for her expertise in that area. And she will be speaking to us this evening about her strategies for determining and incorporating the use of bioidentical hormones in her practice, both to promote fertility and to address other gynecologic issues. So that is our great panel. And following the individual presentation, Christine is going to moderate a discussion among the panelists. And then finally, at the end, the last number of minutes, we'll have questions and comments from the audience. And that's it. So without further ado, Christine, take it away.
Thank you so much, Peter. I'm so excited to be here. I'm completely honored to be a part of this panel with women that inspire me and just have taught me so much. So I will get started with my presentation. Let me pull it up. I'm also so excited to hear theirs and to lead a discussion at the end. So here we go. All right, today I'm going to talk about lifestyle medicine for reproductive well-being. We heard about me already, but I really feel, to me, I'm an acupuncturist and a Chinese herbalist, but one of the really big things that I do with my patients that are coming to see me for fertility is work on lifestyle, because I think that it has been a huge benefit for women as they're going through the fertility journey, not only to optimize their health, to help them be in a better place to get pregnant, but also to help their well-being along the way. It really can help ease the stress and the burden of going through the fertility journey, to work on some of these lifestyle medicine tools. So here in traditional Chinese medicine, we have this saying, we say, we want to cultivate the soil before planting the seed. And I just think that's a beautiful example of what lifestyle medicine can do and should be doing for women as we're getting ready to get pregnant. So we know that lifestyle medicine can support preconception, but it also protects the health of the next generation, which I also am very passionate about implementing lifestyle medicine for. So research is showing more and more that not only can these lifestyle medicine tools help with success for achieving a pregnancy, but really that preconception health of the woman and the man can also help to have the child, the offspring, have a lifetime of health benefits. And the opposite is true. If we're going into a pregnancy in poor health, we can consistently see in the evidence that we're having metabolic issues, diabetes can be more common, obesity, cardiovascular disease. So I really feel passionate about not only helping women with lifestyle medicine to help them get pregnant, but also because we're helping impact future generations. So what is lifestyle medicine? The definition is that it applies evidence-based whole person lifestyle change to prevent, treat, and even reverse disease. We look at lifestyle medicine using 6 pillars. First, nutrition, physical activity, stress management, restorative sleep, social connection, and avoidance of risky substances. So when I got this program started, we happened to get together with the Vitamix Foundation, and they also had a shared vision for these ideas. Their commitment is to building a healthier futures together. And so they have a vision of cultivating a nation free of diet-related diseases, and the foundation places its focus on maternal and child nutrition, encompassing preconception, pregnancy, postpartum, and the crucial first 2,000 days of a child's life. The foundation actively supports research efforts in this domain. So I applied for a grant for this 8-week program that we developed through the Vitamix Foundation, and they felt passionate about this shared vision that we had, and we received the funds to be able to start this program. So the goal of my program was to improve the preconception health and well-being of women going through the fertility treatments by providing lifestyle medicine education and community in a shared medical visit setting. These are group medical visits. We have about 10 women or so with 1 or 2 providers to educate about different topics. And along with that, we added the implementation support and accountability through individual health coaching. I know for me, I talk to my patients every day about the right lifestyle choices to make, and I still found it really hard in my life to make those choices on a regular basis, to implement exercise or eat the right things or go to bed early instead of watching TV. And the thing that actually helped me implement the changes that I wanted to make the most was working with a health coach. So I thought this would be a really important tool, especially for women who want to make these changes quickly because they want to achieve their families as soon as possible. So having some accountability and support to make these changes seemed like a really great fit for these shared medical visits. So we started an 8-week program. We have 4 shared medical visits that meet every other week. We do these visits with an advanced practice provider and the health coach that manages the program, as well as the 10 participants, and we educate on different lifestyle medicine topics. Our topics include, we call it prepare and relax. So we work on habit building and mindfulness practices. Our second session is nourish, which is about nutrition. Our third session is Move and Restore, where we talk about exercise and restorative sleep. And our fourth session is called Integrate, where we talk about supplements that could be helpful, avoidance of risky substances like toxins, and integrative therapies like acupressure, massage, things like that. And then in between those shared medical visits, we have 4 health coaching individual one-on-one sessions. So the participant will learn about habit building and mindfulness, and then the following week they'll meet with the health coach to implement some changes that they would like to have in their individual life. This has been really helpful because, as you can imagine, 10 women coming together on a journey, we have a variety of people at different places in their life. Some might have their diet completely honed in, but they really want to work on stress management. Whereas another patient might still be eating fast food 5 days a week and really wants to work on incorporating more vegetables. So it's kind of hard to encompass all of that in a shared medical visit alone. Having that one-on-one session can really help meet the patients where they're at and help them achieve their individual goals. And then lastly, we worked in some field trips, we call them. These are ways for our patients to connect and experience hands-on education like cooking demonstrations, exercise classes. We have a big focus on strength training, fertility yoga, relaxation practices. We've incorporated heart math breath work, forest bathing, sound baths, and acupressure training so they can treat themselves at home. Another big thing that I think is important in fertility is that lack of connection that's happening. So women often feel very isolated and alone on their journey. So the reason that I wanted to have this as a shared medical visit was to have that community that they can be a part of and women that they can talk to about what they're going through. So I was going to talk about each session and some of the things that we focus on, the first one being prepare and relax. Our focus is really strategies for building new habits. We show little videos about habit building. We have discussions about how to build healthy habits. We give resources like books, habit trackers, each other, and being accountable with a friend. There's apps out there now where they can be accountability partners through an app. So we try and help them bring these connections into their life. Strategies for setting themselves up for success, talking about SMART goals, and really just giving a variety of practical ideas. And not every single one of those ideas is going to fit into their life, but maybe something will connect and they will be able to take that and give it a try. And in that session, we also focus on relaxing. And so we discuss stress. So there's eustress and distress, which is a good stress and bad stress in the body, and how it can impact our body. And we talk about how we're all going to have stress, but it's our mindset that matters most. And there's research out there that shows there was a really large study, around 30,000 participants in the US, that showed if you believe that stress is going to harm you, they actually ended up having worse health outcomes in their life than people that didn't believe that stress would impact them in a negative way. So we talk about ways to shift our mindset and to realize that there are things that we can control with stress, but then there's things that we can't, and our mindset is what really matters there. We also talk about stress management strategies and ideas, and we share amongst each other what might be beneficial or what they find useful. We teach relaxation practices like breath work, mindfulness and meditation, journaling, gratitude, and then that experiential piece, the field trips. I mentioned sound baths, which we started at our office. We have somebody in our office who does forest bathing, so we meet together at the beach or at the forest preserves here, and heart math breath work. So our second session I called Nourish instead of Nutrition, because to me, I think women that are trying to get pregnant need to work on nourishing themselves in every sense of the word and really feeling fulfilled and nourished by what they eat, nourished by their rest, nourished by the people that are around them and the thoughts that they have. So I really love this idea and this word of nourish when we start thinking about the food choices that we're going to make. We talk not so much about what to eat. I feel like it's really easy for women to find, blog posts and articles and books about what food to eat. We do put a focus on the Mediterranean diet, anti-inflammatory eating, whole foods approach. But our big focus in the session is actually how do we implement that into our lives? Because you can tell me what to eat, but then how do I do that once I get home? So we put a big focus on strategies for implementing the healthy eating. We have, I don't know if any of you have ever checked out the Copy Me That app, but it's amazing. You can grab recipes from blogs and it dumps it into your Copy Me That app and it's free. And we have a group Copy Me That recipe database. So we share recipes. It's helpful when you try something new if you know somebody else who ate it and loved it. So we have this group Copy Me That database. We have resource lists that we give. We talk a lot about batch cooking and ideas on how to make it easy to eat healthy and what some things that everybody does to make that happen. And then we finish it off with a cooking demonstration, which we actually do virtually because we give recipes out ahead of time. And we have the women, if they would like to cook with us, we have somebody that's doing the demonstration in their kitchen, and then you can cook with them at home. So that's been really fun. Our third session is to move and restore. And our focus here is on exercise. And there's always a lot of questions and a variety of places that people are at, I would say, in their life with movement and exercise. Some are trying to actually decrease the intensity of their exercise and maybe do more restorative exercise or just try and be okay with moving their body in a less intense way. Some are really trying to up the exercise that they're doing in their life. So we talk a lot about exercise intensity, how much we should be getting, what it should feel like. We also talk about the importance of strength training for women, because I think that's something that women tend to avoid or don't realize that it is so important for us, our hormones, our health, our bones, our glucose metabolism, all sorts of great things happen when we build muscle in our body. So we talk a lot about strength training. And just about moving our body throughout the day regularly, because a lot of us work at computers, we're working virtually from home, and it's very easy to get stuck in a chair for hours on end. So we try and encourage each other to move regularly, take those bio breaks. And then we talk a little bit about pelvic floor health with it, which I think is not talked enough about with women. So we take this opportunity to do that. And then we have fertility yoga and strength training as part of our experiential. We also talk about the opposite end, getting some exercise, moving our body, but then how do we get some restorative sleep so that we can recover from that exercise and from the day and really heal and repair at night. So we talk about the importance of good sleep, which a lot of people know, but again, it's how do I implement that to get that good sleep? So we talk about healthy sleep hygiene. We talk about circadian rhythms and really respecting the light-dark cycles, because that's how our body is trained to respond to know when it should be awake and know when it should go to sleep. And we also address sleep disorders like sleep apnea. And then our last session is integrate. So here we talk a lot about toxins. That's the bulk of the work that we're doing in that fourth week, particularly endocrine disrupting chemicals. We talk about each different chemical and how we're exposed to it, and then how to minimize our exposures to these toxins. It's definitely a rabbit hole that can get scary if you go down it. So we try and focus on the things that are low-hanging fruit that we can control in our life, and that can have a positive impact on the burden that we're putting on our body or not putting on our body. We talk about supplements that are safe for everybody and that are great choices. We don't get into things that are specific for each individual, but more so high quality supplement choices around prenatals, vitamin D, omega-3, things like that, that would be beneficial for all women, and what would be safe to continue in pregnancy and what should be stopped. And then the experiential here, we're doing group acupuncture this session. And after the group acupuncture, we're teaching a small amount of self-acupressure training. So like a little routine that people can do at home and implement into their fertility journey. In the past, we've just done virtual self-acupressure training. So this time we're having it in person to receive actual acupuncture as a group. So we're excited for that. And we've had some really great feedback from participants. We even had a media story done on the news. Some of these are really special to me to hear about at the end. This woman said, I filled out the survey, but I wanted to thank you for putting together this program and really advocating for us in our journeys. I have made more progress mentally, emotionally, and physically in the last 7 weeks seeing you three than I have in almost 2 year for an infertility journey. The amount of confidence and strength you instilled in all of us at each session was so powerful. And another woman said, this experience was lovely. Thank you, lovely ladies, for everything you did to put this together. I am really hopeful that what we learned will help me not only be successful on my journey, but also enrich my personal life in the long run by teaching me how to prioritize self-care. Thank you again. You were all wonderful. And I know I've had another patient say that it helped remove that feeling of being alone on her journey. So to me, that was very special to hear as well. So that's the end of my story. If you have the opportunity to provide women with a resource like this where you can have them get together and educate in a group, I would definitely jump on it and give it a try. And I am going to pass the mic over to Dr. Lee Hullender Rubin. Thank you.
Thanks, Dr. Christine Kaiser. That was beautiful. I'm so excited to hear about this project. I mean, and it goes right into what I'm about to talk about. So let me share my slides. Here we go. If I can get here we go. So can you see my slides? Thumbs up. Yes. Okay. So my name is Dr. Lee Hullender Rubin. I'm a doctor of acupuncture and a board certified herbalist. I'm going to talk to you about integrating research into clinical practice and I'm going to do that through a case example. So in addition to being a researcher and a clinician, I'm also a teacher. So I like to do a lot of case-based presentations. So let's get into this person named Clara. She goes by she, her. She just turned 34 years old. And I'm going to move everybody out of the way here. And she wants to have a child before she turns 35, and she's really struggled with trying to conceive. And so she's planning on doing an IVF with donor sperm, and she's single. So that's why she's doing that. And she has had one pregnancy and one termination, which there was no complications with that. So here's some history about Clara. Her FSH is elevated, as you can see. Her LH is starting to creep up a little bit, and her AMH and follicle counts are clinically low. And what really got my attention, though, actually, when we were talking, because I see a lot of people like this, and they go on to have babies, actually. But what got my attention in her particular case was that her menstrual cycles, they were irregular. Her cycle length could be anywhere from 28 to 118 days on one occasion. They are occasionally nearing 4 months of no menses, and that's an important marker for us. They started to become more irregular as a few years ago as her business began to take off and her sleep and her nutrition patterns began to change. So currently, her menses are painful with purple red blood, with a heavy flow with 2 days of 1 to 2 inch clots. So for us in Chinese medicine, these kind of details are very important in our diagnostics. And she would have roughly 3 to 7 days of purple/red spotting. So clearly her menses from a Chinese medicine perspective is not smooth nor regulated. And not surprisingly, because it's irregular, she does not track her ovulation. She finds it very irritating. And on occasion, she would notice cervical fluid for about a day, and it was thin. Another important thing for us in Chinese medicine. Also notice that her menarche was late and that she was born premature to older parents. So when Clara presented to see me, she had been diagnosed with diminished ovarian reserve. And like many modern people, she's working extremely long hours in a high-stress job. And she reported feeling fatigued, having poor appetite, loose stools with occasional urgency, not getting enough sleep, but sleeps well when she does sleep, liking to be warm, but not having night sweats, so that's good. She does get some bloating and increased irritability 3 to 5 days before menses. And as a young person, she did smoke about half a pack of cigarettes a day from age 15 to 24. So from an objective perspective, the tongue, the pulse, palpating the abdomen, these are all important for us in Chinese medicine. I won't go in great detail here other than to say it's clear that her tongue shows us that there's deficiency, that there's some dampness that's accumulating and some blood stasis, in addition to her pulse also showing the same thing, as well as a yang deficiency. Her abdomen was cooler to touch, as well as her legs, and more soft with pressure, although she did have more firmness in the upper abdomen. And she was positive for something called oketsu, which indicates blood stasis. She did have some mild swelling around her eyes and fingers and toes, and the ultrasound showed that her ovaries were a bit on the smaller side. So I want to return to her biomedical diagnosis for just a moment. She's diminished ovarian reserve. And so what is that? There's no universally agreed upon standardized definition. The European Society for Human Reproduction and Embryology, they have the Bologna criteria. This is one particular criteria that more people are using, but there's still others. You need to have at least two of the following features in order to be diagnosed with diminished ovarian reserve. Either you've had 2 episodes of a poor ovarian response with maximal stimulation and you aren't advanced maternal age or have an abnormal ovarian reserve testing. That's like elevated FSH, low AMH, and a low number of antral follicles. Or you could have advanced maternal age of being 40 years or older, or have any other risk of a poor ovarian response, like let's say you had chemotherapy, or maybe you have a genetic marker that predisposes you to something like this. You could have a previous poor ovarian response where there are 3 or less eggs retrieved after a conventional stimulation protocol, or there could be abnormal ovarian reserve testing where the antral follicle count is less than 5 to 7 and the AMH can be less than 1.2. Now, the Poseidon class stratification is really it's like a prognosis tool. It's kind of giving us an idea of who's going to be a better responder. They've really bifurcated this by age. So 35 years old is really the important age here. So people on the left, they can either have normal markers and just didn't respond well, or they have abnormal markers. On the right, the upper right hand, these are people 35 and older. They have normal markers. They don't respond as well. And then in the lower left is the lower right is the group 4, which is over 35 and over rather, and they have abnormal markers. What's important to know about this is that this is really kind of telling us how likely are we to have aneuploidy. What is our aneuploidy risk? So if you're under 35, low embryo I can say the word, I really can. Low embryo aneuploidy risk is more likely, whereas 35 and over, it's much higher. What's also important to note is that, you're going to get fewer embryos with each cycle, and that also reduces your cumulative live birth rate with ART. And when you think about this, the age of 35 being the bifurcation line, it makes sense because when you think about ovarian reserve, we already know that the most precipitous decline in the reserve ramps up at age 35, which you can see by the letter B here, notated on the graphic. This is also noted, interestingly, in the 2nd century BCE, before the Common Era, classical Chinese medicine text, the Huangdi Jing, also called the Yellow Emperor's Canon of Internal Medicine. What they noted is that the age of 35, the reproductive capacity begins to show its first signs of decline. How they knew that back then, it's just really astounding to me, and it's been found to be true in the modern era. So let's come back to Clara. Clara, what she really wanted to just try to do as much as she possibly can, but the truth was she could not come frequently. So I put together a treatment plan, and I wanted to give her Chinese herbs, but her doctor was a hard no on them, and I understand that, so we did not do it. It's a little frustrating in the situation where she's a clear candidate because of many factors of being gene deficient with blood stasis, digestion being poor, but we do what we can. So he also did not want her taking any additional supplements beyond CoQ10, a prenatal fish oil, and vitamin D. And due to her schedule and geographic location, she could only commit to coming to probably once, possibly 2 times a month. So here's what we did. In the clinic, we would do acupuncture. So I would try to see her. We would do acupuncture and we would do photobiomodulation therapy. And that could be laser and LED. Now, for acupuncture, why would we use this? How might it work? We have 5 particular ways that we think that acupuncture may work. The first thing is that it can inhibit central sympathetic nerve activity, which can then cause a vasodilation. It can increase circulating endogenous opioids, which can really mitigate the stress response. We know that people with fertility challenges have some of the highest levels of stress. We also know that acupuncture can increase the release of neurotransmitters, which can have an impact on the hypothalamus, pituitary, and ovarian axis, which may then come downstream and have an influence on ovulation frequency, menstrual regularity, and ultimately fertility. The other 2 things that are important is that it may help with sugar metabolism. So it can increase the skeletal muscle glucose uptake and clearance, as well as decreasing hyperinsulinemia and increasing the insulin clearance. So what we know about people who with diminished ovarian reserve, does acupuncture help them? There's one meta-analysis where 787 patients across 13 studies, what they found is that when acupuncture was compared with any control, it did decrease FSH with a pretty good effect size and a large effect size. And then it did decrease the FSH-LH ratio. It increased AMH with a small effect size, and it increased antral follicle counts. Moving forward seems to be a challenge here. Here we go. So does acupuncture help people with diminished ovarian reserve going through IVF? Well, there's a small study of about 30 people. What they found is that acupuncture and IVF significantly increased the number of retrieved eggs in those women aged 37 years or older. And they were going through more than one controlled ovarian hyperstimulation. They didn't really see any difference on birth outcomes. And a scoping review found that these particular points were the most commonly used to treat this particular condition. Spleen 6 and CV4 were used up to 74% of the time, and spleen 6 and stomach 36 were used up to 52% of the time. Now, another thing that we use is photobiomodulation therapy. This is a light source placed near or in contact with the skin, allowing the light, energy, or photons to penetrate tissue where it interacts with chromophores that are located within the cells. And this results in photophysical and photochemical changes that leads to alterations in molecular, cellular, and tissue levels of the body. So I use laser. It's a non-photothermal or non-heating therapy. It's a class 3B laser. It can penetrate more deeply than class 4 lasers and is allowed for us to use in the state of Oregon and some other states. I'm not sure about Ohio. I did not check in on that. Maybe Christine could tell us that. The other version of PBMT that we use is LED, so light emitting diode therapy. And these are panels that can cover a larger geography, but they're more superficial in their light penetration. It's an incoherent light, so it stays more superficial. There's no data on it that it confirms egg or improves rather egg or embryo quality, but there is some reasonable effects that we might expect could have an impact here. So light induces a complex chain of physiological reactions in diseased and damaged tissues to accelerate wound healing and tissue regeneration being specific for us, and increasing circulation, reduce acute inflammation, reduce acute and chronic pain, and restore normal cellular function. So by looking at these particular mechanisms, there is a plausible explanation for why this could be helpful. But the evidence is very limited for fertility and diminished ovarian reserve, but it signals possible benefits. Let's just show you a couple of them. There's not a lot. Most of it is observational. What they have reported out of Japan is that laser may be associated with an increased chance of pregnancy, but they didn't have comparison groups, so this makes it hard to kind of be able to use this as a great generalization. And the final study here is a giga laser, which is a larger laser placed over people's abdomens. 400 women, 65% of them became pregnant after 6 treatments. So that's not a lot of research, but it is still enough for us because it's safe. I feel comfortable using it. And I'm going to be publishing a case study here in the near future. Now at home, because she can't come see me as much, I wanted her to do some treatments at home. So one of those is transcutaneous electroacupuncture stimulation. And this is basically a TENS machine on acupuncture points. So you're using TEAS for acupuncture point stimulation based on the electrical stimulation signal instead of traditional hand-twisted needling. And it's a really easy way for patients to do treatments at home. There's no needling, it's comfortable, and they can do it at their own convenience. So how it works is that you're using an electrical stimulation to activate the nerve endings or the fibers, which then generate action potentials, which then are transmitted to the central nervous system, and that stimulates specific chemical mediators, which look a lot like how acupuncture works. There's one additional function that has been found with TEAS specifically, and that it may increase, it's the last one here on the list, it may increase the density of endometrial pentapodes during the window of implantation, which can be very important for people going through frozen embryo transfers. Other things that we've seen with diminished ovarian reserve is that in 5 studies with over 1,100 patients, TEAS improved clinical pregnancy rates by 32%. In people with diminished ovarian reserve, it improved antral follicle counts, AMH and FSH levels compared to placebo. And in people 35 years and older, T significantly improved clinical pregnancy rate, implantation rate, and live birth rate. There's this is just, I wanted to give it to you for what is the group consensus coming out of China on how to use Ts to support ovarian hypofunction and to promote embryo implantation. And this is what we did for this particular patient. So this is based on work done by Dr. Elizabeth Stinner-Victorin's group out of Sweden. They chose these points specifically to improve blood flow to the ovaries and to the uterus. The other aspect that it has is it actually improves some of those markers for glucose metabolism. We also, because this patient has a kidney issue, I included from the consensus the kidney support. This is how she did it. She did it once every other day, 3 times a week, 3 to 4 times a week rather. Now, the other thing that we did, much like what Christine just laid out as part of their program, we did supporting the whole person. So helping her breathe, helping her nourish herself, helping her sleep, move, de-stress. So I loved what, I would love to bring that here to Portland. So hopefully I can learn more about that. So what happened with Clara? So we did 4 months of treatment. She did implement the T's treatment. It definitely improved her sleep. She was able to get more hours. She said no to some new work. She was having more regular stools, better energy. Her abdomen was no longer cold, less bloating and cramping. And she had menses that were starting. She had 2 menses before starting treatment. So when she went through a controlled ovarian stimulation with a freeze-all cycle, her AMH actually had improved. It was 0.9, and her antral follicle count went really high. There was 11 of them. That actually is getting closer to normal. They were less than 9 millimeters, or a little bit larger. And she continued acupuncture weekly during the stimulation. So she stayed closer to where we were. She still did the T's at home during the controlled ovarian stimulation. It resulted in 13 eggs retrieved, 11 fertilized, 6 were biopsied, and 4 were euploid. That's pretty astounding when she started with very few, like 3. So we resumed weekly acupuncture for the frozen embryo transfer when she was ready to do that. And she continued doing the T's as well, only doing treatments 1 and 2. And she ended up with a single pregnancy with using it was the first transfer using the 5AB embryo, and she delivered at 40 weeks, 4 days via cesarean delivery. So with that, I will pass this over to Dr. Amy Sapola. Let me stop my share.
Thank you so much. All right,
You're welcome.
I will get my screen share going.
Oh no.
All right, and can I have a thumbs up that everyone can see that as well? Okay, great. So I'm going to talk about food as medicine for fertility, and there's so much here, but this is a very, very brief overview. As Christine mentioned at Connor, one of the groups I've had the pleasure of just starting to kind of work with is one of the fertility support groups. And so one of the things we did was just have a night where we were making non-alcoholic beverages in my kitchen on Zoom, and so bringing in practical ways which answer not only kind of what to eat, but like how to do it, I think is really important when we talk about like food as medicine, because food as medicine can be a little bit of a triggering phrase for people. I think it's really important to first understand that food is really just fundamental. So I think, certainly we can use food, and how I see food as medicine is really this quote here is a reaffirmation that food and nutrition play a role in sustaining health, preventing disease, and as a therapy for those with conditions or in situations responsive to change in their diet. But again, I want everyone to remember just food is fundamental. So I think it's really important, as Christine talked about in the beginning, to shift from this mindset of deprivation and restriction, this diet culture mindset, to mindfulness, self-care, connection, and true nourishment. So it's also important to point out that it is not just the mother's responsibility. I see this all too often, that we only talk about mom's diet and totally ignore that dad's diet matters too. So both partners are very, very important. Today, I'm mostly going to talk about mother's diet, but certainly both partners are very important. I like this work by Deanna Minnick. This is a little more abstract, but when you think about the energy of the food that we're eating and what sort of energy we're bringing into our body. She did a really nice job of kind of bringing this into like a visual graphic. So, is the food that you're taking in, does it feel healing to the body? Is it depleting? Is it energizing? Is it scattering, right? And so as we look at food, you can kind of get this sort of picture of like, what is the energy of the food that you're about to eat? And do you find that it's going to be nourishing to the body or something else? So it's also important to understand that there's more to optimal health than just vitamins and minerals. That's where phytonutrients come in. Some people call these phytochemicals as well. But it's basically the color, the fragrance, and the taste of food. So the nice thing about phytonutrients is you don't need any like special tools to measure them. It's literally as long as you can see and smell, you can assess the phytonutrients in a food just by the richness and the color and the fragrance and the taste. So again, this color, the rich colors, the darker colors are going to be richer in antioxidants, which is especially important for fertility when we're looking at cell proliferation and supporting the metabolic system as well as reducing inflammation. So when we look at time to improve pregnancy, a few things kind of stand out. Just generally speaking, a higher intake of whole foods. In this study, they talked about fruit specifically, minimal intake of fast food and sugar sweetened beverages, and a lower glycemic load. Also avoiding trans fats. And this is actually really interesting because in 2018, the FDA banned trans fats. However, still, if they have less than 0.5 grams per serving, they can be marketed as 0 grams of trans fat. So there is still trans fat in our food supply. Trans fat, we know, increases inflammation and insulin resistance, which can adversely impact ovulatory function. In the NHS2 study, they found that trans fatty acid intake was actually associated with a greater risk of ovulatory infertility after adjusting for co-founders, and also women with the highest intake of trans fats had reduced kind of conception within one cycle, like menstrual cycle. So, foods at home that you'd want to watch out for are generally like crackers, cookies, cakes, frozen pies, and other baked goods that you're getting out of a package, like those ultra processed foods. Snack foods like microwave popcorn, frozen pizza, vegetable shortening and stick margarine, coffee creamer, and refrigerated dough products. When you're out at restaurants, this could be pastries, pie crusts, biscuits, breaded or fried chicken, seafood, French fries, other desserts, and breakfast food. So the World Health Organization recommends less than 2.2 grams of trans fat per day. So as you can see, if less than 0.5 grams can be considered zero, and all of these different foods may have less than 0.5 grams, really easy to get over that 2.2 grams a day. The next thing that's interesting to look at, and how I kind of wanted to walk through like an example of using not only food as medicine, but applying this culinary medicine perspective, is when it comes to omega-3s in fish. So 2 servings of fish of low mercury, high omega-3 fish. So typically the acronym like SMASH fish is used with salmon, mackerel, anchovies, sardines, and herring. But I also often recommend people go to the EWG Consumer Guide to Seafood to actually calculate based on, I think it's age, weight, all sorts of different factors, specifically the fish you're looking to eat, where it falls kind of on the spectrum of low or high mercury, as well as the omega-3 content. So higher fish intake was associated with higher likelihood of blastocyst formation, but higher blood mercury levels were actually found in females experiencing infertility. Retrospective time to pregnancy studies among women residing in counties surrounding the lakes Erie and Ontario, which is particularly important to our Cleveland chapter, were found to have high PCB contamination. And they found that maternal fish consumption for 3 to 6 years compared to none from lake fish was associated with reduced chances of conception. So here are some sources of, first on top is the omega-6s, which are generally thought of as more pro-inflammatory, although we do need some in our diet. The ratio is just kind of way off right now. Typically, we'd say, you know, ideally a 2-to-1 or a 4-to-1 ratio. Oftentimes in the standard American diet, I've heard up to 20-to-1, is what we see. So quite imbalanced, but essentially increasing the amount of omega-3s in the diet. So how do we do this from a culinary medicine perspective, right? Because we can talk about omega-3s, but it's somewhat abstract. How do we actually share with patients, like, how do you put this into practice, right? So maybe it's sharing some recipes. So this is a salmon dish. In this dish, we have the salmon, which is going to be a rich source of omega-3s. We have coconut milk, which will have some medium chain triglycerides. We have garlic, which if you crush it ahead of time, again, can help support healthy blood pressure, healthy cholesterol. We have the broccolini, which will contain sulforaphane, which is a phytochemical or phytonutrient that basically can help with detoxification, healthy hormone balance. We have olive oil, which we know is nourishing for the body. We have carrots, and which are a rich source of beta carotene and vitamin A, which is again important for our reproductive health. Onion, which is a rich source of sulfur and helps promote detoxification, and cilantro, which actually some studies have shown can be important in men's reproductive health as well. So in this simple dish, we really have a lot of kind of wisdom that our bodies can use. So just a few words about broccoli. So broccoli actually, as soon as it's harvested, basically starts losing nutrients relatively quickly. So broccoli is not something that you want to like bring home and stuff in the back of your fridge and forget about. It's something that if you can, getting it local and buying it fresh is going to preserve the nutrients more. Vitamin C is kind of what declines fastest. And you'll see here too, one of the things I like to talk about when we're talking about culinary medicine is also taking into consideration. Oftentimes we hear it's too expensive to cook healthy or, too hard, too time consuming, all sorts of things. But how can we actually use a plant from root to leaf or root to flower, right? Like using as much of the plant as possible so that you're not wasting money and you're not wasting food. So for example, with broccoli, using the stems, which are a really rich source of fiber, to make something like a broccoli slaw in addition to using the flowering parts that we're used to. Another thing I like to talk about is when we talk about cost, sometimes frozen vegetables are more practical. They store longer, they're less expensive, and they're usually harvested at peak ripeness. So they're going to be nutrient rich. The one thing I always like to point out when we're talking with fertility patients, but really with anyone, is to watch out. We don't want to be microwaving in plastic. So although this bag recommends microwaving in the bag, you do not want to microwave in plastic. The other thing for this recipe, carrots are in the recipe. And it showed these nicely julienne carrots. In this case, we don't recommend, or at least I don't recommend, typically peeling carrots because the phytonutrients of a vegetable are typically concentrated in the outer layers, or at least most concentrated, because that's where essentially, if you think of it as the plant's immune system, that's where the plant's primary defenses are. So you're going to have more phytonutrients. So obviously, washing carrots is important, but you actually don't need to peel them. Making sure that you're getting carrots that are grown in healthy soil, but just chopping them up as they are. When you see these carrots, these are actually the cores of carrots, which are not bad. They still are a fine source of fiber. They taste good, goodish. But you will have more nutrients if you actually just use the whole carrot and cut it up. So this is a great statement to think about is when does the apple stop being the apple and start being you? We know that the food we eat is information for the body. And that's part of what we're teaching is that food, what you eat really becomes the body. And this comes from Ayurveda, that the actual last tissue to be nourished is the reproductive tissue. So really important to think of how do we layer or how do we nourish all of the layers of our body. So again, at Connor, what we were doing is some cooking demos and having these conversations. One of the things I like to avoid is dietary dogma. So, not being really like, oh, you have to eat this way or that way, but it's really bringing in whole foods. How do you eat closer to nature? How do you maybe consider less than 5 ingredients on if you're looking at a food label? If it has more than 5 ingredients, it's more likely to be an ultra processed food. So how do we eat with less than 5 ingredients? Um, if you're eating a packaged food, just those simple tips can really be a game changer. So, next, without taking up too much time tonight, I wanted to talk about yoga for fertility. And this is something I'm especially passionate about. So, the first thing I always ask when someone comes in new to fertility yoga is, what is your intention? And typically the intention is to conceive. That is a different intention than many people going to other yoga classes. And it's important to acknowledge that and recognize that fertility yoga is practiced with a different intention. So we're not there, for many of the other reasons that people may come to yoga. Oftentimes it is more based on the asana, the movement, right? The kind of like the exercise that you may get. But this is really about focusing internally, focusing on yourself, focusing on bringing blood flow to kind of the abdomen, to the pelvic floor, and really nourishing the body. So there are a lot of different types of yoga. And I was actually talking with one of my friends who is a yoga instructor about this. And we were saying, when someone when a healthcare provider makes a recommendation, like, you should consider yoga, it's sort of like, depending where someone goes, they could have 100 different experiences because yoga is not one thing. And there's many different styles of yoga. There's many different types of teachers. So really important to have some idea of what you're getting. Just generally speaking, classes that would be more supportive for fertility would be specifically classes called Yoga for Fertility, gentle yoga, restorative yoga, yoga nidra, which is like yoga, kind of like yoga sleep, but it's a more relaxing, kind of meditative process, or a slow flow class or somatic yoga. Less supportive for fertility would be your hot yoga, power yoga, yoga basically in a heated room, intensive heat producing practices, or a fast, slower vinyasa yoga. If you think about the energy that you're expending, you're putting out more energy than you're taking in. And what we want to do with fertility yoga is to bring energy into the body, not to essentially like lose energy or deplete the body. So, one of the beautiful things about fertility yoga is it helps to connect women with their cycles, with the cycles in nature, like the moon cycles. It really brings us together. So, as Christine and Lee both talked about, it's about this connection piece too. So, in a fertility yoga class, you're with other women who are on the same journey, which I think is really important to the process. Some of the yoga for fertility benefits are that it increases energy and blood flow, especially in the heart and the pelvis areas. At the beginning of a class, I'll often have women lie down, kind of relax their legs on a bolster, and place their hands on their lower abdomen. And just feeling the energy go from the hands into this lower abdomen region can be very kind of calming in its own right. It also stimulates the reproductive system directly by focusing on the ovaries and the uterus, supports and helps to regulate the endocrine system, reduces levels of stress hormones in the blood and or in the bloodstream. And fertility yoga really adapts poses according to the phase of a woman's monthly cycle. And I'll talk more about that in a second. It also calms the mind, reduces negative thinking, and opens two-way communication channels between the mind and the body. Also uses yoga, meditation, and visualization to help synchronize messages between the conscious mind, the subconscious mind, and the body, and balances the feminine and the masculine, or the yin and the yang energy in the body. It also increases apana, or the downward flow of energy in the body, and samana, which is the digestive and absorptive energy in the body. And it builds that life force, which in Ayurveda we call ojas, which is like this kind of like just like vital force. So again, this is about tuning into your cycle. So if you're coming into a fertility yoga class, we're going to be talking about different points in the menstrual cycle, and participants will probably gain the most benefit if they know where they are in their menstrual cycle. So fertility yoga is in tune with the cycle, not only the menstrual cycle, but like the cycles in nature as well. As well as the moon cycles, right? So, for example, when you're in the follicular phase, what we would cue is more being doing more of the movement, more of the twist. When you do a forward fold, the legs would be together, so you'd be doing a little more compression on the abdomen, and then using blocks to frame the front leg. Again, if you're in a lunge and you put blocks for the hands where you're framing the front leg, your torso leans forward, and again, you're compressing that lower abdomen. In the ovulatory phase, then it's going to be similar to the phase, but a little more gentle. And then in the luteal phase, or during that 2-week wait, we would do more slow and gentle movements, no twists. And when we do forward folds, we would have the legs more open, so a wide-legged stance so that you're not putting quite as much compression to the abdomen. And then blocks would be to the inside of the front leg, again, so you're not compressing the abdomen. And then during the menstrual phase or IUI, that's when we would practice more of a restorative class. So doing more um, kind of supported postures where you're just taking time to relax and restore. So as far as the research goes on fertility yoga, as well as kind of yoga in general, participants in fertility yoga had higher IVF success rates, decreased stress, and better quality of life. Fertility yoga participants had higher retention for treatment, decreased anxiety and depression. They had significantly higher pregnancy and birth rates in patients doing IVF who incorporated mind-body programs specific to fertility, which included yoga, meditation, and cognitive behavioral therapy. And then a 2018 literature review of 87 studies found that yoga can help increase the success of ART by improving physiological and psychological states, and then relieving anxiety, depression, and enhanced regulation of the sympathetic nervous system. Also, meditative yoga decreases markers of psychological and physiological stress, and reduces inflammation and improves sleep. So that is all I have. I'll go ahead and hand it over to Tara.
Well, I have really enjoyed everybody's presentations, I wish all my patients went to all of these things before they came to me, especially that 8-week. I didn't know you guys were doing that. Look, we're just right down the street from you. So love to hear about what you guys are doing. So obviously, as we do have a health coach that works with us, probably not to the detail of all of your programs, but I think that as I mentioned, that's a great foundation for fertility. So just as a review, kind of when we're looking at the patients, I mean, we want to make sure that there's no anatomical problems, such as a fibroid or any Müllerian defects. Obviously, you need to have sperm that has the right motility and count. You need to have somebody who's ovulating. You need to have open tubes. And then in the absence of any problems with those, it's usually labeled unexplained infertility. The menstrual cycle, as Amy mentioned, so there's a lot of changes within the menstrual cycle, and knowing where the problem is, if there's a specific symptom that the patient has, for example, breakthrough bleeding, it's always best to kind of determine where it is in the cycle. So as we look at it, the first phase of the cycle, we talk about follicular phase. By day 5, you're going to have a dominant follicle, and that's why most of the time day 3 is when the the ovarian reserve blood work is done, because by day 5, one follicle is going to step forward and become the dominant follicle. The increasing estradiol sends a signal back to the brain to suppress FSH. In the middle of the cycle, that's when ovulation occurs, and that's what we would be detecting with ovulation predictor kits, the LH surge, and then again, the luteal phase. So knowing when the symptoms are, if a patient has persistent spotting in the middle of the cycle, for example, or a couple days before the period, that could signal something different. And all of these hormones need to be in tandem and balanced. So we also track ovulation by menstrual temperature, a basal body temperature. We have an Oura ring now that can do that as well, as far as in addition to the temperature that you have at your bedside before you come out. And that raise in temperature is only about a degree or so. So at birth, you're born with 1 to 2 million follicles. And so a lot of the follicles are actually lost to degeneration. And so when we have diminished ovarian reserve or advanced maternal age, what's happening is the rate of follicular degeneration is faster, and you have a less quality of eggs. So by the time perimenopause comes around, you have only about 3,000 left. So we have these stages of reproductive aging. And so during the reproductive phase, it's defined as early, peak, and late. So you can see that even in the late reproductive phase, which is well before the menopause transition, you start to get these abnormalities in your endocrine system, such as variable FSH, depending on the day of the cycle. And if we're talking about day 3 or 4, you could start getting a low AMH. And even though the AMH is studied only in the studies has been for people undergoing infertility treatment, I don't know that there's data on just random AMHs for people who aren't currently not able to conceive or have had 6 to 12 months of infertility, but I know that we are checking it more and more. And I've even had some people in their 20s have low AMH. And then, so what's the consequence of that? So one of the things that we look at is we look at the balance of the hormones, not just the levels. And we do look at something called estrone, which is the type of estrogen that's made in peripheral conversion. And I find a lot of patients that have what we term estrogen dominance, not necessarily because they're not making enough estradiol or progesterone, but they have too much estrone. And one of the problems is our environment. So, already in some of the lectures that we've heard tonight, they've talked about the dirty dozen, the clean 15, and also plastic. So happy to hear about all that, because we do go through that with our patients as well. And that even just eliminating disposable water bottles, we've had patients experience a difference in their menstrual flow. So hormonal causes are what, when they get to me, is what I'm trying to determine. The most common thing that we see is polycystic ovarian syndrome, which you do have to have 2 criteria to have that. One, either you have high testosterone on a blood test or clinically in the form of hirsutism or acne or hair loss, and irregular cycles. So if you don't have those 2, you technically don't have PCOS, but you can be fertile with PCOS, but this is a common cause. Premature ovarian failure, which is now called primary ovarian insufficiency. And again, the precursor would be diminished ovarian reserve. There's a lot of other causes to that. And we see a lot with mycotoxin, Candida infections, other toxins, Fragile X mutations. There's probably more genetic markers that are out there as well. Just aging, women are postponing their childbearing. The luteal phase defect is one of the things that we see a lot, and it doesn't seem to know an age barrier. So I'm starting to see that in younger and younger women, and then just not ovulating. So a lot of the things that, for example, in the 8-week course that you guys are doing, which is discussing stress, mindfulness, diet, those are all triggers that are going to raise cortisol, and cortisol can suppress ovulation. So other causes that we also see are nutrient deficiencies, as I mentioned, toxins and heavy metal, mold exposure, methylation issues, which methylation is kind of a generic name, which it actually describes a chemical process, but it has been translated to be involving with MTHFR, COMT, which I'll show you a little bit about that. As I mentioned, estrogen dominance as well, and stress. So what we normally do is we do testing on day 3. Anywhere between 2 and 5 is ideal, but 3 is the best day, which we're getting the estradiol, the FSH, and anti-Müllerian hormone. I'm generally going to check a lot of other metabolic labs at this time also, because they generally know when their day 1 is. Day 1 is full flow. So I would be checking thyroid labs. I would also be checking insulin, glucose, A1C, because we're looking for metabolic features, and probably inflammatory markers like a CRP. In day 21, we want to see, and if they know when they're ovulating, or if they have any indication of ovulation, like middle schmerz or cervical mucus changes, we would go 7 days after that. Or if they're doing ovulation predictor kits, if they're having a 21-day cycle, we would hit day 21. But again, a lot of these patients are having a 24-day cycle or a 35-day cycle. So I arbitrarily say mid-luteal, which is day 21. And so we want to do at that point, maybe repeat the FSH and LH, but estradiol, a serum progesterone. We're going to look at a DHEAS and a total and free testosterone. And then those are the traditional testing, but what we have in our practice is what we call functional testing, which would be cortisol, saliva testing, urine testing, which I'm going to show you a couple cases with that today. So this is a case of a patient who had some GI and GU symptoms, and she had already done her genomics. She was heterozygote for MTHFR at 1298. So we have a lot of information about 677 and 1298. MTHFR is involved in the folate cycle, and also if you have a slowdown of that enzyme, you could have a high homocysteine. This is supposed to be H and MT instead of N and MT. That involves histamine, so that could also affect your fertility. 1B1 is in the first phase of estrogen detoxification, and glutathione is GST, and then COMT is phase 2. So I'll show you kind of what that looks when we look at one of the dried urine testing. One of the things we do for a lot of our fertility test patients are a GI map, which is microbiome testing, and PCR testing looking at the gut. So we all know that it starts with the gut, and you guys are intuitively dealing with gut issues in food, and food is medicine, but sometimes there are other triggers that can lead you to have abnormal bacteria in the gut that can impair your fertility. So with this patient, we did do it, and we saw that she had some overgrowth of what we call commensal bacteria, and then her beta glucuronidase was high. So that's an enzyme that is made by dysbiotic bacteria, which causes estrogen to be recycled. So when you have estrogen detoxification, it's obviously excreted in the gut, but then this enzyme could send it back into the circulation, and that can actually impair fertility as well. This is a snapshot of methylation. So we have the methionine cycle, which makes homocysteine. Here is where we see MTHFR here, which is the folate cycle. And then I also see abnormalities down here in COMT, which is phase 2 of estrogen detoxification. So with this patient, we did what's called a cycle map. And so that's where about 11 different times throughout the cycle, they are doing salivary an analysis, a sample, salivary samples. So you can see down here, day 3, 5, 8, 11, 12, 14, 16, 18, 20. And so based on whether they have a short cycle or a long cycle, we're getting these. So this was an interesting one, because if I would have only just gotten a day 21 reading on her, her progesterone actually looked quite high, and her estrogen did not look that high. So you can see that her estrogen is really low here, and then she kind of has this weird drop at mid-cycle, and that's a lot of times where she was having some of her symptoms. In addition, with this, normally you would get this is estrogen detoxification. This is urine samples. So you can see this is her estrone, her estradiol, and her estriol. They're all high. These dials, I think, make it really easy to look at. This is phase 1 estrogen detoxification. These are the 3 enzymes, cytochrome P450. And so the balance of these does matter. So you can see that we don't want to have a higher percentage of the red. We want 7.5 to 11, and she's got 15%. So that's the first phase. And this second phase is COMT, which high is good, low is bad. So for her, we can give nutrients and supplements to augment and induce those enzymes to work a little bit better. So I'm going to just go back for a second. So here, see, and this was the result of those nutrients. You can see how much lower that percentage went from 15 to 9.2. Things like N-acetylcysteine and resveratrol can do that. In addition, with this patient, you can see that her DHEA is pretty low. So that's one of the things that has been linked to infertility, which I have some studies later in the presentation. With this patient, we did give her micronized progesterone for luteal phase support, and I also did start her on DHEA. So this I wanted to have you guys see how we can manipulate estrogen detoxification and what that would look like on a dried urine test. So this case is a patient who came at 40. So we already know, you know, she's advanced maternal age, and she had already been seeing an infertility specialist for controlled ovulatory stimulation. And so she wanted to come to me for kind of an alternative option and to see if there's anything holistic to do. She did not get any periods. She did not bleed unless she was on oral contraceptives. So when she came to me, she had already had an AMH, which was 8.8, which was great. And she was given progesterone support, but they didn't give it to her just in the luteal phase. They just gave her continually every day, which progesterone out of phase can suppress ovulation. So that's not actually helping her either. 100 milligrams may not be a high enough dose to suppress ovulation, but nevertheless, we don't give it that way in patients trying to conceive. We don't start it till after ovulation. So her problems were, you know, energy, she had acne and skin issues. And so she was taking a break from the fertility medications and wanted to see what could happen. So we did do a GI map with her. She had bacterial overgrowth. She also had candida, so we treated that. And her labs from a previous doctor showed a TSH of 3 and a free T4 of 0.9. Now, while those are not abnormal, there's some data in the reproductive literature that having a positive TPO and I don't want to say subtherapeutic, but a TSH higher than 2.5, which is still normal, that could be associated with an increased incidence of miscarriage. So obviously we wanted to get her TSH better, her T4 up, and her TPO down. And according to this, her DHEA for a 40-year-old, that's pretty low level. There's a wide range for DHEA and DHEAS. So we kind of know that around menopause, optimal is about 150. So it's got to be higher the younger you are. So a DHEA of 100 is pretty low. So I actually started on levothyroxine or in the form of Tyrosint, which is a pharmaceutical for levothyroxine without any dyes or fillers. We treated her gut. We changed her progesterone to cyclic, and she was very, very sensitive to the 13 microgram, which is the lowest dose it comes in. So I actually had to compound her a very low 2 microgram. So for context, 25 micrograms is the lowest dose of something like Synthroid. So very, very low. But she did get benefits of feeling better, but just couldn't tolerate that. And then we started low dose naltrexone for her. And so these were, and as of the next time I saw her, the goal was for her to have spontaneous periods, which what she did. She was having more regular periods. We told her to start her progesterone on day 14. She was still having a hard time titrating her thyroid doses. But I think the key to this patient is getting her TPO antibodies down. They still, you know, we always have them go gluten-free. And sometimes gluten isn't the trigger. Sometimes it's also other inflammatory foods like dairy and not necessarily lactose, casein. So you can see her FSH and her LH still look anovulatory, and Candida was still positive. So it takes a long time to treat Candida overgrowth, which we either see in the gut or we see with serum testing for Candida IgG, IgM, and IgA, or Candida immune complex. And a regular lab like LabCorp or Quest will run those. We treat them either with prescription antifungals or herbal options. We give them the option. So this was just a study that I found. I wanted to kind of touch on the DHEA and the CoQ10 as part of the fertility protocol that we have. And so this one actually looks at TAS. So I thought it was nice that Dr. Rubin also had that in her talk. So this one looked at some network for poor ovarian response, and what they saw was that CoQ10 and DHEA had advantages. And the DHEA they used in the study was 25 milligrams 3 times a day, which is actually a very, very high dose. And so CoQ10 was the best in improving the live birth rate, and DHEA improved the implantation rate. This was another great review article. This was published in 2022 about interventions. So they did 14 different interventions, including immunotherapy, anticoagulants, HCG, micronutrients, lifestyle, endocrine, pre-implantation. So some artificial techniques and some not. And so the only comparison of statistical significance was low dose progesterone versus high dose, where low dose was associated with lower odds of miscarriage. So they had different endpoints, miscarriage and conception. And so, luteal phase, if it's low, we always will supplement progesterone in the luteal phase. And then the data for antioxidant supplementation in women had an increased live birth rate. So that would be things like CoQ10. This was just a schematic of all the different progesterone. And I put this in here because there's lots of different avenues. They looked at vaginal, they looked at IM, they looked at rectal. So I don't think there's really a standard for that. We usually just give it orally. Continuing on with the same study, CoQ10 in people with poor ovarian reserve or PCOS was good, even though it wasn't statistically significant. And there were 3 randomized controlled trials that levothyroxine in people with a normal TSH but positive thyroid antibodies helped. So again, I'm also looking at how's your energy? Maybe the endpoint isn't just conceiving, but also do they feel better when they're on the levothyroxine? And then the benefit of DHA in live birth rates, and there was a trend toward less miscarriages, but it wasn't statistically significant. So the interventions with the at least moderate quality were low dose progesterone, antioxidant therapy in men, and DHA and or testosterone in women. I probably would shy away from the testosterone in women. It's not a good idea to give it orally. There's no FDA approved for women, and it's got to give it topically. So it's going to hang around for a long time when you give it topically. And then if you have a female fetus, we don't want any virilization. So DHA is a lot easier to give, and it will increase your testosterone. So other causes, as I mentioned, a lot of times we'll do something called micronutrient testing, which is both a micronutrient, so intracellular or RBC nutrients. It has an omega check. It has, and also a second part of the test is organic acids in the urine. That's looking at microbiome markers, Candida markers, dysbiosis markers, and metals in the RBC. So that's a good kind of overall test. Again, unfortunately, it's a very involved test, not covered by insurance. Some of our patients will do a genetic evaluation, and certainly, for Fragile X, if you're looking at diminished ovarian reserve, but we're looking for methylation problems. If we're going to check for microtoxins, it's going to be a urine test if they have a known mold exposure or any other symptoms associated with that. And then, as I mentioned, the stool testing. The things that you guys already covered for me were detoxing your environment, which is great, eliminating inflammatory foods, and then potentially liver or bowel cleanse, depending on genomics and what we're seeing on estrogen detoxification testing. So basically, when we approach our fertility patients, we're going to balance the nutrients. We're going to talk to them about a lot of the things, preconception that you're covering in your classes. If they need progesterone, we're going to start it 2 days after ovulation. I didn't have an example of cortisol here, but all of the things that you're doing with yoga and mindfulness and heart math, we love heart math in our practice, is going to treat cortisol abnormalities. If we are doing a cortisol test on a patient, we're doing 4 points throughout the day, either in urine or in saliva. And then obviously we want to treat any mold, metal, or dysbiosis. So that is the end of my presentation, and anyone's welcome to kind of follow me in any of the social media challenges or channels. So yeah, I was glad to be involved in this panel, and I thought everyone, gave such an integral part of fertility treatment.
Thank you so much. Yeah, I felt the same way. It was exciting to see what everybody chose to talk about and how they intertwined, and I learned so many new things. And I think one thing that stood out for me, Amy, with your talk, you had said it just blew my mind when you said, when does the apple stop being the apple and start becoming you? And I just thought, oh my gosh, that's an incredible thing to try and grapple with, and really encourages you to pick better choices when you're making your food choices. But I had a question for you with that. The nutrient-rich foods, you said, like the food that nourishes the reproductive organs, it's something that happens last. So do you feel like there in Ayurvedic medicine, is there certain foods that help to get all the way to those reproductive organs, since, you know, they're being depleted as they go? And
Yeah.
what's the advice that's given there?
Yeah, that's such a good question. So in Ayurveda, it would be kind of incorporating obviously seasonality, but also looking at those foods that are more like nourishing, right? So I'm thinking about root vegetables, which would be grounding, but then incorporating healthy fats like ghee, as well as some like complex carbohydrates. All of those things again help nourish like multiple tissue layers. So it is bringing in some of those good fats, which I think for people of my era, you know, going through the 90s and kind of the fat-free craze, that still can be difficult for people to be okay with. But bringing
Embrace.
in, yes, embracing some fat in the diet and pairing those with vegetables. And we know, you know, Ayurveda has this great wisdom, and we know now too, just confirming that phytonutrients like chlorophyll, like beta carotene, and many of our fat-soluble vitamins like vitamin A, D, E, and K are all better absorbed when paired with fat. So I think it's just bringing that wisdom into practice.
That's awesome. Well, I know that we may have some questions from the audience. You're welcome to put them in the Q&A. Otherwise, I also wanted to open it to the panel. If anything stood out in somebody else's presentation that you'd like to hear more about, go ahead and ask. And I have a quick question for Lee, actually. Can you explain the difference between TENS and Ts? Like, what's the difference there?
Yeah, it's actually it's hard to kind of really differentiate, other than to say that where you're placing the electrodes are on acupuncture points, 1. 2, we are using different settings. So instead of using a really small pulse wave, which is best for pain, and a really high intensity, like 100 hertz or 200 hertz stimulation, that's really meant to like numb the tissues. Like you're just trying to flood it with all of the pain-killing chemicals you can possibly get, and also tell the brain, hey, there's nothing to see here. With Ts, we're using a low hertz, so it's 2 hertz, and then we're also using a very wide pulse wave. So it's really impacting so the same way that acupuncture does, the manual acupuncture, and like, you know, stimulating the same fibers as acupuncture does to downregulate the central sympathetic nervous system, all that other stuff. So the timing of the treatment is pretty similar. Like for pain, for TENS, you could do 15 to 30 minutes, but for Ts, you want to do roughly 30 minutes for the best effects.
Are they the same device, or would you get a different device? Okay.
Yeah. The only thing I would just say is like those pre-programmed things that have like little symbols on them, and you don't really know exactly what it means when you choose that particular. It says it's cup. This one's for cupping, or this one's for acupuncture. Like I don't know what any of those really mean.
Yes.
I like to use the ones where you can actually adjust
See the hertz and
yes, exactly.
Yeah. And then are you placing pads over acupuncture points? Is that what you're training your patients to do?
Yes. So
Okay.
yeah, exactly that. Yeah. I give them a picture. I explain it to them. We demonstrate it in the clinic. We then talk on the phone if we need to again. And the handout also has links for finding the points more easily.
Thank you. We do have a question in the chat. It says, any suggestions for male infertility factor? Example, weaker sperm, sperm with higher disintegration rate. Seems most infertility treatment is focused on the female. So any specific testing or suggestions for male partners? Anybody want to take that one?
I mean, I can start with that. So obviously for a man, I'm going to check, I probably would do micronutrient testing as well as the organic acids. I would love to do a GI map on them as well. from a testing standpoint. Hormonally, you know, obviously you can't give testosterone to a male infertility patient, but I'd want to look at their adrenals, and I'd want to look at their cortisol levels and their DHEA. Obviously, everything that you're doing, I think, would apply to a male as well, with diet, stress, and mindfulness, and everything that would be the precursor to the testing that I would do.
I totally agree. I often, you know, mostly women come to see me, not the men too. So I often tell the women, whatever I'm telling you, your partner should be doing too. And so trying to get them on board as well. We actually had that request in our group. The women would come and they'd say, I have a hard time explaining to my partner, you know, I'm so inspired by you guys, but how do I translate that to my partner? So we actually had one of our naturopathic physicians, Jacob Wolf, do a hour-long video that the partners can watch with them, with the women in our group, so that they can have an explanation of some lifestyle things that men can do to help with the fertility journey for the couple. So the women have been really grateful to have that to share with them. And I would say another big thing that I talk to my patients about with men is that reduction in toxin exposure, particularly things like marijuana, because I think it's seen now as being, you know, not a problem and safe, but actually there is a lot of research that how marijuana can be so detrimental to sperm in a variety of ways. So I usually have to print out an article or two and some research for them to share with their partner to convince them, but and also to explain that it takes time when you make these changes for the effect to show up in the sperm. So, you know, that spermatogenesis is about 90 days, and we need to do this work for a little while before you see that outcome, and not just before ovulation and then go back to their ways. So sometimes that takes some convincing too.
I think along that same vein too, when it comes to alcohol, we know that 40 grams of alcohol can damage sperm and testicular tissue. So 40 grams of alcohol is about 3 standard drinks. So being really cognizant about alcohol intake in both the female and male partners.
Absolutely. Yeah.
I would also add that, you know, acupuncture has been found to increase sperm motility and sperm counts. Morphology has been a little less responsive with, I think it's 6 weeks of treatment. Then there was also an additional paper that was looking at transcutaneous electroacupuncture stimulation specifically for people with subfertile motility and count. Again, morphology wasn't measured in that study, but we definitely see those two parameters improving with treatment.
Another thing I would say with relation to diet is we focus a lot on prenatal vitamins for women, but we know that the standard American diet is quite deficient, with more than half of the standard American diet consumers being deficient in multiple nutrients. So I would say really just baseline, making sure the male partner is not deficient in any nutrients. Also, folate is very important to both partners. So, you know, the green vegetables, right? Those sorts of things that are rich in folate can be beneficial.
Could I just make a comment that I was really interested, Amy, in what you had to say about the types of yoga that were beneficial for fertility and the types that weren't. Make total sense, because all the types that were beneficial are what we say in Chinese medicine are like yin types, and all the types that were not beneficial were yang types. And if you are trying to nurture and develop something like a fetus, you definitely want to develop the yin and not expend the yang. So that is cool.
Good. Thank
Yeah,
you.
I liked the idea of bringing energy in that you said, instead of depleting energy, like when you're thinking about the exercise, because it's we're teaching about movement tomorrow. And so I was just talking with our health coach about how do we explain, you know, not overdoing it. And that's a challenging concept, because some people, you know, they've been going to Orange Theory for an hour a day for years, and it doesn't feel like overdoing it to them. So how do you get that message across? And I really like that idea of bringing energy in, and Peter talking about the yin, like that material that you're trying to build. And you can't do it with no material. So that's cool.
Good.
Right. And, of course, there are situations where you would definitely want to strengthen the yang. Like if somebody has got a luteal phase deficiency, then you have to develop the yang. Somebody has a follicular phase deficiency, then it's the yin and blood. But, I mean, it's more complicated than that, but, those are some basic differences. But even when you're strengthening the yang in a luteal phase deficiency, you still need to strengthen, nourish the yin and blood as well to not lose the fetus, basically.
Absolutely.
So that's my 2 cents.
Well, it looks like it's 8:30 and this was an awesome, awesome panel. Thank you
Totally.
everybody for joining us.
Yes, thank you so much. And Christine, thank you so much for leading. Everybody, thank you for your contributions. And I just want to say that, again, there's a recording that will be available in a little while, not sure exactly when, probably within a week or so. And we will send out a notice to everybody who registered for this to let you know when it is available. And other than that, if you want to join our mailing list and find out about other upcoming events, we always have great events, then please do so for free. Amy put the link into the chat at the beginning. And I'm sorry, Christine, did you want to say, finish up with anything else?
No.
I didn't think I might
No,
have.
thank you so much for having us, Peter. We had lots of fun.
Okay. All right. Thanks again, everybody. Good night. We'll talk to you soon.
Good night.
Thank you. Good night.